Thank you for joining the Bearing Health webinar. I'm Mary Barbato from BearingOn.Health. Today we'll be exploring digital health reimbursement models and implication of those models from regulatory to pricing and marketing and sales. Brian Abraham, Senior Director of Market Access and Patient Services at Eversana. Brian has developed and implemented market access strategies and teams from early stage through commercialization. He has helped companies acquire appropriate reimbursement coding, as well as help develop coverage policies. He has worked closely with the Centers of Medicare and Medicaid Services and the American Medical Association on behalf of manufacturers in a variety of technical and policy issues. Welcome, Brian.
Thank you. Nice to be here.
And we also have Adam Kaufman, PhD, BearingOn.Health's publisher and editor-in-chief. Adam is an accomplished executive, entrepreneur, and board member providing leadership in digital health, medical services, and healthy living. For more than 2 decades, he has been a pioneer of digital health and its accompanying transformation of the healthcare industry. Welcome, Adam.
Thank you, Mary. We've got a lot we want to cover. So what Brian and I were going to do is think about the 5, maybe 6, if we add one, different ways that we're seeing digital health commercialize. And then very quickly go through each of those models, talk about an example, talk a little bit about the implications for regulatory, and then some of the considerations for sales and marketing. We want to get through all of these, so call it 3 minutes per. Brian, thank you for joining. I've enjoyed working with you over the last year.
It's a pleasure to be here. Enjoy working with you too, Adam.
So first, let's think about reimbursement for digital health programs through a model that looks like durable medical equipment.
Absolutely. The first model is a lot of what folks think about when they first want to commercialize these digital products. So durable medical equipment itself means that the product is dispensed for use outside of the healthcare setting, most often in the home. It has a life of at least 3 years. It's able to be used by more than one patient, and it's used for a medical purpose. And also kind of a footnote to that, it has to be an FDA-defined medical device, not necessarily a cleared medical device, but one that meets the definition of a device. An example might be, we at Eversana have been working with some companies that have done it with VR. They have this standalone device, which is always helpful when we're talking about DME, and having that standalone VR device has helped them get into the DME space.
That's very helpful, Brian. So in that model, is there a specific DME code set? Where's the reimbursement for DME coming from?
When we're talking about Medicare, the coding is actually from CMS. Even beyond Medicare, you would usually use what we call a HCPCS code. When we talk about DME, it's one of those 5-digit codes that starts with an E. It is issued by CMS. It seems straightforward, but there are some nuances to it. Over the past couple of years, CMS has also added onto that whether or not you would qualify as DME, and also what your pricing would be. And so all of those things combined in that one DME application to CMS are going to be evaluated at least during one cycle, if not more than one cycle by CMS, evaluation cycle, which happens twice a year. What they would do is basically look for the qualifications for DME first as the coding is applied for. And then if there is evidence that they can look to pricing, they'll also look for that and start the DME fee schedule process as well, so that the product could appear on the Medicare DME fee schedule. As Medicare chooses its payment level for DME, commercial insurers, other payers can choose whatever they want, even if it's attached to that same HCPCS code, that same healthcare common procedural coding system code. Just because it has a certain price at CMS doesn't mean that that payment is the same with other payers.
With the VR example, you hit an interesting requirement, right? So a VR company could take just their software to market. We'll talk about other models, but really if you wanted to go through the DME model, it has to actually commercialize the hardware with it. What are some of the other implications? Maybe we could talk a little about who actually can sell DME and some of the distribution.
Sure. So we look to suppliers or distributors to sell DME. And interestingly, physicians are automatically qualified as suppliers. It's just whether or not they actually want to stock these things and sell them. But basically, what would have to happen is a supplier would have to be qualified by CMS to distribute the product and then would accept the payment on the fee schedule.
So to summarize, the manufacturer of the digital product that wants to go through DME theoretically could become a supplier, but often the manufacturers are not the suppliers themselves. So you got to think about another a player in the channel who's actually going to distribute the physical product for you. And I'm sure there's a lot more, but let's move on to the next category. So the next way that we see digital health companies go to market is through what we're calling physician administered. And it's one of the broader, more interesting, and I think bigger categories, at least recently. But Brian, do you want to define what we mean by that and maybe an example there?
Sure. It's when a physician buys a device and then dispenses it or prescribes it to a patient. Here's where we see digital diagnostics and those types of items where they might be undertaking remote therapeutic management or remote physiological management, RPM and RTM. Then what they do is they bill for their services based on the prescription, and then the patient has the product, and there may be a subscription to it, or there may be other ways of payment to it. It's where the physician is administering the product and is following the patient through the use of that product and billing.
I like to think of this model as the digital health company is essentially a technology company, often selling something as a SaaS model or maybe a license to a physician who then is using the product to deliver some service that they can bill for. And often those services, if you think about the RTM coding or diagnostic coding, requires the use of some tool, but it doesn't necessarily require the use of that specific tool. And so interestingly, the commercial model, as I understand it for the digital health company, looks like any other enterprise go to market, and it's the healthcare provider then to package it up in some way that they can bill a particular claim. Now, some of the tools go further and actually get involved in the billing, so that's another implication. Anything else you think that companies thinking about this model need to be aware of?
Yeah, so instead of selling through suppliers, they would be selling to the providers. They would be selling to basically those who are prescribing and helping them understand what it means to be billing for the use of the product.
And we've seen, as we've worked with companies, whether it's digital diagnostic or RTM, one of the things they have to be concerned about is what does it take for the provider practice to actually be able to bill the code that embeds their technology and get reimbursed for it. So we do see a lot of the digital health vendors thinking about the reimbursement to the provider, even though they're not actually the provider. And at the end of the day, there's a subscription. But you can imagine that if they're charging something for their service and the physician isn't able to recoup the billing, then the cash flow doesn't work for the physician practice as well.
Exactly.
So let's move on to what I think got the most press for a while as potential models. What we're calling the pharma or PBM style. It's the one where the digital health product itself is wrapped up as a product that gets coding and is billed like it were a drug through a pharmacy benefit. Say a little bit more and give us some of the examples.
Yeah, sure. So you're exactly right, Adam. It's really having these products placed on a formulary. There are some pharmacy benefit managers out there and insurers that actually have digital formularies. Not a lot of them, but a few. And they evaluate these products. I'm not going to say the same way, but in a similar way that they would evaluate and actually tier pharmacy products. This type of product is really what Pear's model was. It's also what Achille was doing. The benefit for the patient was under the pharmacy benefit rather than under the medical benefit. And by using the pharmacy benefit, it would be in a formulary. The physician would actually prescribe the product, and then the company generally dispensed the product, opening up a subscription or something like that. Really, what the challenge was and has been, continues to be, is that the payers haven't really decided where they want to put these types of products. Some of them are moving forward with the pharmacy benefit, with the digital formularies, But many of them are also looking at it as a medical benefit and not quite sure where it goes. And if you're a developer or a manufacturer, you have to be ready for both. And that's a challenge in itself.
It clearly brings a lot of sort of both regulatory and commercial implications. One of the ways I've thought about it is the digital product is trying to mimic what a pharmaceutical product would look like. So briefly touch on what does that mean from a regulatory pathway, getting to the point where they can even think about reimbursement.
So from a regulatory pathway, it's not a pharmaceutical per se, but it actually does need FDA marketing approval or clearance. Really, payers won't even look at it unless there is FDA marketing approval for it. That is a rather steep regulatory hurdle.
So there's at least a couple milestones. So FDA approval, actually getting the code set, and then what does that actually in itself doesn't imply you get a reimbursement rate for it. So walk us through that part of the
Right, absolutely. So even if it is on a formulary, there is still this medical component to it, or could be this medical benefit component. You'd have to apply to CMS for coding so that it would be recognized by a number of payers. These companies did in getting coding, but it ended up being more generic coding. So it was really hard to identify specific products using the coding that existed and really exists now, at least for those couple of products. In this space, it's kind of a catch-all code. And what we as an industry are doing is working towards making that catch-all code more specific and getting more specific codes as products come out so they aren't in general limbo and Medicare administrative contractors can choose to pay kind of whatever they want rather than there being actual value ascribed to that code.
And then we play the journey forward. So you have to get the code. There's a market access energy to get reimbursement for that code at a rate that's relevant. And then what we realized for a lot of the companies who went this pathway is even as they walked that difficult journey, the commercial model was still to detail physicians to prescribe something to have it then adjudicated through a pharmacy benefit.
Yeah.
And the cost of reaching physicians to get the prescription, to know the normal drop-off is also very high. So it's a viable pathway. I think we are unfortunately seeing the glass is more than half empty for some of the players, but they were able to achieve real revenue and in some ways bigger than some of the other categories. But the cost and time it takes to go through that are normally built for tens of millions, not hundreds, if not billions of dollar pharmaceutical drugs. And so often it's hard to warrant the cost that it takes to go through, including all the way at the commercial where you're detailing individual physicians to convince them to write a prescription, to have a patient fill it, and then you have all the trouble of the copays and the explanation of benefits and all of the other elements.
I just want to tag on to that yeah, companies were successful in getting coverage with a handful of payers, but they needed more resources to keep getting that coverage at more and more payers. And that was a big challenge.
So let's jump to the other extreme, the model that we're calling programmatic spend. This exists at both health insurers. It's probably the most common way that when people say let's approach employers, they mean approach employers for their programmatic spend. So briefly define that and give us an example or two.
That was exactly how I was going to define it, that you go to an insurer, it's part of a wellness benefit or another, what I'll call a non-claim benefit package. In other words, you're not making direct claims for each time a product is used, but you're providing it as an overall benefit for patients and making it available to either the whole or certain parts of your membership. Some examples might be disease management tools, muscular tools, smoking cessation apps. Early in the game were mental health kind of applications.
And to your point, the way I think about it is the programmatic spend is a separate independent budget as opposed to the pool of money that is meant to go against the medical or the pharmacy spend. And so an employer will have a budget. My experience with employers, for example, is they're aware that it's kind of out of one budget or the other, but they actually manage that budget very differently than they do the medical spend. And we see a lot of companies go this way. They end up looking like tech-enabled services because often you have to take on the engagement of the employer or the member. You've got to take them through a journey. There's a kind of an enterprise reporting. And then sometimes they become pathways to go to the other billing models as well. So often it will start that way, and then they get some experience, are able to justify it, and maybe they find that there's a claim there as well. We've got one more. Talk to us briefly about the model of going direct to a consumer.
So this is consumer use with no insurance involvement. Examples would be health trackers like fitness trackers, women's health, cardiovascular, those types of things. As far as regulatory implications, there really is no regulatory implication. It's
Well,
all
actually, Brian, we should be clear. There's probably not a lot of FDA regulatory, but we have seen
right.
companies run afoul of like the FTC and some of the
Yes,
commercialization. So they end
absolutely.
up looking like consumer companies, and they have to be aware of the regulatory environment in their marketing claims.
For sure. There may be the opportunity that insurers, kind of like in the programmatic spend, they may reimburse for fitness tracking now and then. It's generally not a provider driven or a company driven reimbursement.
So the last, we don't want to call it a model, but we've seen a lot of companies go this way, which was actually becoming a provider themselves. So what we mean by that is you could think of what we're calling the physician administered tools. So you have some solution that you could sell to a practice of some type and they could bill a code. And what we've actually seen is a lot of those companies end up hiring those clinicians, setting up some type of clinical practice and billing those services directly. Or they maybe have a very innovative product that could fit in another category, are having trouble commercializing it, and they're standing up full virtual care businesses where they have physicians and other clinicians that are billing, and then they're differentiated by or made better by those services. And I'd love your opinion. I don't actually put that as a strategy commercializing digital health. It is a way to leverage a digital health asset, in my opinion, to be a differentiated or distinct provider. I think the best example in my mind was Oshi, which started trying to pursue a prescription digital therapeutic in GI and is now one of the leading virtual care companies with a almost full clinical stack, GI specialty practice. Anything you want to just say about that model?
I think that it is certainly something to consider. I could see more of these types of companies becoming providers, especially in the elder care space and the cognitive space. There are certainly challenges here because to become a provider, there are lots of hurdles to overcome, both on the payer side, where you have to register as a participating provider with Medicare and with all of the rest of the insurers. And there are also state licensing requirements to become practitioners or to have practitioners on your staff. So it is not an easy one and done type of process, but there are a lot of benefits to it to be able to bill directly to these payers as participating providers.
So I think we've covered the 5+1 commercialization models and reimbursement strategies. Please send in questions to Mary. Brian, I'll start with one. Just any kind of guiding stuff that would help you drive towards one of these models or the others, or what are the first sets of questions you'd ask that would help a company decide which of these models, or sometimes more than one, might be most appropriate?
I think that what we'd want to do is look at the product itself and say, okay, how is it built? Does it have a hardware component? Is it meant to be bolted onto something else? What is the therapeutic area? Because some are easier than others. Some are already established in the coding world and others have yet to be. We want to take a global look at it and understand really what makes this product tick, and then go through our process and really look at all 5 of these models and pressure test them.
Any advice for a company that's building what could be a pharma style or maybe physician administered, but not targeting physicians? The big use case that they're referring to here is targeting a therapist who doesn't have prescribing ability. Is there a way around that for those cases where the clinician who's the target usage is not someone who can prescribe?
We've worked on these kind of products, and these clinicians are influencers. It's a very popular term today, but the clinicians really are influencers to the physicians who can prescribe. And if they believe that there is a technology that will help a patient therapeutically, the physician is certainly going to listen to them and could very well prescribe.
Last question. Given all the challenges of pharma style reimbursement, what are the characteristics of a product where you might recommend somebody go down that path?
It's a great question. I think that one of the things is, do we have the clinical evidence to go to the payers and say, this is proven to have positive outcomes? And by providing peer-reviewed evidence, I think that would be a good candidate to go that pharma route.
And I think that the thing I'd add in response to that is, of all the models, that's the one that likely can support the highest unit price. And so for potentially areas where there's maybe not as much volume, but it has a real strong clinical impact, it can prevent major progression of the disease or other costs, it is easier to justify higher price points in the pharmacy adjudicated benefit than some of the other categories. There are other questions coming in. We are out of time. Thank you so much, Brian, to all of you.